this morning. All right. Oh, another day of radiology followed by psych, which probably is best the other way around. Gives you a chance to understand your feelings after my class. Right? Okay, so picking up where we left off yesterday was our last slide of our, really mostly our pleural effusions, right? This was that hydropneumothorax. Don't get so hung up on the pneumothorax. In the next lecture, we're really going to break down how do we see those on x-ray, okay? So when I pointed out the white arrow yesterday, if you all didn't see that, or you're kind of doing the squinty eye thing, that's okay. We haven't learned that part yet. That's coming later today into tomorrow in the next slide deck, all right? So as a review, right, there were two general causes of pleural effusion. It was really just the increased rate of formation of the pleural fluid or the decreased rate of absorption. That's simple, that's straightforward. No disease processes or anything like that. It's just understanding that there's more fluid in the pleural cavity than there needs to be in that aspect. But more commonly, you're going to see it through trauma stuff, but we'll do a little more of that. Okay. X-ray reviews. So now this is where we're going to turn around and we're going to look at a couple of different things. So what's the first thing that jumps out to you guys? We're going through and looking at it. Okay. So maybe they heard knobs a little large here. Okay, the coshophrenic angle blunting, right? That's the big shiny toy. The coshophrenic angle blunting. Right, so I don't have any, I mean, this is nice and rounded here. So that's step one, so that knows we know we have a pleural effusion, right? So I will tell you there are other things on this x-ray that are slightly abnormal as well. So I don't think the clavicles are very rotated. They look like they come in right here, the sternal area here, the edges are here. Here, my spinous processes are fairly centered, so maybe a little bit, but nothing that kind of stands out majorly. Yes, the sternotomy wires.
Is there a fusion up on the upper right there?
What are you looking at?
That thing, yeah.
That guy right there.
Yeah.
And I also heard that's a big heart. Good, right? We're getting it from different areas. So yes, cardiomegaly, and yes,
Fissure.
this guy right here. So now what do we know about our anatomy, right? Is there a fissure in this area of the right lung? Right? Not really. Those were kind of like here in the right lung. So here and here, or here and here. So what have we talked about that looks like this, in this kind of a position, pointing down towards the mediastinum that this could be? Say again? Atelectasis. So this is a very small subsegmental atelectasis sitting right up in here. So good, right? Small, not pulling structures over yet, so that's not necessarily, it's an indicator. We're trying to distinguish between an atelectasis or a big pleural effusion, but it doesn't have to be that way. So yes, this is a small atelectasis sitting in the right upper lobe. So good. Those are pretty much the things I wanted you to see, was the blunting, the cardiomegaly, the widening of the aortic root, and the atelectasis. Yes, sir? Possible, right? So he's like, could we be thinking Dressler syndrome because of all these things and looking at the sternotomy wires and prior surgery? Here's the problem with this, with just the picture. How old are those sternotomy wires? I don't know, right? I would need to give you a vignette telling you the patient is recent post-MI or recent cardiothoracic surgery, that kind of thing. So yes, I like that your thought process is, I'm starting to see these pieces of Dressler syndrome. That's on my differential. Now I want to know, have you recently had an MI? Are you in a post-MI state? And I can put that in a vignette. Yeah. So good thought process. Now you guys found, as a class, the 4 major abnormalities on this chest x-ray. So that's good. Okay, that's the kind of stuff you're going through and we're looking at. And if we do, just for funsies, even though we got like the coshophrenic angles and the blunting and stuff, let's take a look, and we said cardiomegaly, right? So I have cardiomegaly. What do I need to know as far as my inspiration goes? I need to see what? 8 posterior ribs. So let's count them together. So 1, 2 here. So 2 comes up. So 1 and 2. So 3, 4, 5, 6, 7, 8, 9. I mean, I would even technically count that 10 just because I can see it go over here and I know it's fluid. But either way, I have at least 8. So we're good. We know that cardiomegaly is not necessarily from poor inspiration. Okay? Could there be enough pleural fluid to kind of push the heart up a little bit? There could be. There could be, but I'm not worried about that too much. If I have my ribs and I don't have any other cause for the large heart, then we're going to call it cardiomegaly. So. All right. What do we call this guy here? The meniscus sign. Good. Right? See how it kind of has that little meniscus sign, that little half semicircle there. That is that meniscus sign. That is how it's telling us that there's fluid in there because we can see that when it gets high enough. That's really what this one's going to show. For you, those of you that are looking at it, do I have some? Maybe. Right? Do I have some cephalization here? Maybe. It's all kind of the same density. When I come over here, yeah, it's not getting darker as I go up, right? So I might be able to call this some cephalization potentially because of looking at that density kind of going up. It doesn't get significantly darker as I go. So that's a possibility as well. Okay. So we've already covered, I know you guys know how to see the blunting of the cost-phrenic angle, so I know you see that. Okay. You guys pulled out the cardiomegaly last time. We have it here again. This is definitely more than 50% the width of the thorax. This one has more prominent cephalization. Does everybody see the cephalization on this one? Look at how prominent these vessels are up here. This vasculature, these pulmonary markings. It almost looks like they should be down here with how thick and how prominent they are. Don't marry yourself just to the prominence, just look at the overall density of the lung. We are not getting darker as we go higher. Okay? Ah, there we go. Right there. Right there. Everybody see that? Small little parabronchial cuffing. Nice dark circle surrounded by a grayish fluid area. So good eye. There too. There as well. Pardon, I wish the drawing thing would work well. It'd be a lot easier than me flashing the light at it. Good. What else do I have? Something we've talked about on this particular image.
Is the trachea being pulled and pushed over?
So it does look like the trachea might be getting pulled over a little bit onto the right side. Okay, so that's clue number 1. So clue number 1 says, okay, maybe I have the trachea pulling a little bit. So now what's another thing that we're looking at? I'm playing guess what I'm thinking, I know. Not necessarily the uncoiling. Silhouette sign, I heard it. Silhouette sign, where? On the right side. Where's my right atrium? I don't know, right? I have this, we would call this a generalized opacity on the right side because I really don't know where it's at. I really don't know exactly what it is. I need a lateral to really fully confirm what's going on with this. But I do have a silhouette sign on my right side obscuring my right atrium. I don't know where that's at. I can't make that out. And then with the other clue that my trachea maybe is starting to get pulled over a little bit, my working diagnosis is probably an atelectasis in the right middle lobe. I need a lateral to confirm that, but I know from the chart that the silhouette sign over the right atrium is right middle lobe. I see some pulling of that trachea on this side, and the only thing we talked about, things that are pulling the mediastinum of the tracheal, is going to be the atelectasis. So I piece together those pieces of information and go, hey, until I get a lateral, I'm suspecting this. I need that lateral to confirm it. Good. Right? I obviously can't ask you in one question all the things that are wrong with this chest x-ray, right? I can't. And this is just showing you another example of how it's so hard to just find one thing wrong, because these patients are usually pretty sick when you're starting to get to some of these things. So read the question. Anybody know what that is? Anybody old enough to know the old Nokia phones? Am I just dating myself? That's what it looks like. I don't know the exact name of it. It's like a special, like transcutaneous pacer type thing. So it's not quite like the exact pacemakers we know of, but it's like a special one that they put in. It looks like somebody just like laid their old Nokia phone on the patient and took the X-ray. All right. What do we got going on here? What did we talk about yesterday that was a subset of pleural effusions that you might think this could be? Loculated. Why do I think they're loculated? Because they don't start necessarily from the bottom and fill up with like a meniscus sign. I got them kind of coming out from the edge here. How can I confirm that if I really wanted to? I would do a decubitus and see that the fluid doesn't change positions. Those are my loculated effusions. Okay? Also got either, can't really fully tell, just with this picture, I would need a vignette as well, but my opacities here, okay, definitely got an extra opacity here that's different from the surrounding lung tissue, maybe a little bit on this side. Could this be atelectasis versus a pneumonia? Yes. Which one is it? How's the patient feeling? What's going on? Are they sick? Are they feverish? If they are, I'm leaning towards pneumonia. If they're not, I'm leaning towards maybe an atelectasis that hasn't started pulling things over yet. Okay. Good stuff. Let's dive a little deeper into pneumonias. What causes it? Bacteria, viruses, fungi. Fungi pretty rare, but for those of you that are going to be stationed in like the Southwest U.S., coccidio is a real thing. Valley fever is what they call it. Unfortunately, that's really hard to diagnose. Usually they come in, you think it's viral, they don't get better. You throw antibiotics at them, they don't get better. You change your antibiotics, they still don't get better. And then you're like, oh, maybe this is fungal. And then you send them for the testing, and it turns out to be that. So, hard to, but there is absolute possible of pneumonia, right? It varies depending on the underlying cause for the symptoms, but again, cough, fatigue, shortness of breath, kidney, tachycardia, great. Fever and chills, guys. Fever and chills. Does that mean in your clinic that fever and chills and lung issues means pneumonia? No, it should just be top of your differential, and in this course, fever and chills. Right? Because all the other ones we've talked about aren't necessarily infectious from like a bacterial or a viral standpoint. These are other abnormalities caused by other things. So when you're trying to decide between those things, use that. Chest x-ray is your initial study. Okay? It says serial chest x-ray may be needed to monitor course. That's going to be more of your fungal valley fever ones. You're going to use it to monitor. In the grand schemes of clinical medicine, you get a chest x-ray, you see a pneumonia, you treat the pneumonia. If they get better, they got better, we're good. Often you will have patients that will come in and go, well, I just want to get another x-ray just to make sure it's been cleared up. And sometimes some novice providers or providers who used to do it a certain way will do that. Don't do that. If they're feeling better, there is no need to get an x-ray for a test of cure. Because the imaging results, i.e. the consolidation going away in the lungs, will lag behind completion of treatment. So studies have shown that those who get the I'm all better post-pneumonia x-ray end up over-treating patients because they feel better, their vitals are good, they're not really having many symptoms, maybe just a small sniffle, but because the x-ray still shows that consolidation, they feel the need to still treat it. When really, if they just would have waited another week or two, it would be cleared up and it would be gone. So typically we don't order post-cure pneumonia x-rays unless you're working towards that fungal valley fever, and the reason for that is that treatment sometimes is 4 to 6 months of the antifungal, so it takes a long time to go away. So really you're just making sure it's not getting worse while they're on that treatment. But you'll learn more about that in home. Yes, ultrasound can be more accurate than chest x-rays. You're not going to use that in your clinic most of the time. You're going to get a little practice with that in your senior semester. CT is your study of choice, okay? CT is your study of choice, with the caveat that you are never jumping straight to a CT for pneumonia, ever. Why is CT the study of choice over chest x-ray? Well, because the detail of the CT, you can really find even those really small consolidations and narrow it down to like the exact lobe. Because when you scroll through the CT, the fissures pop really nicely too, which we'll see when we do our CT scavenger hunt towards the end of the course. So that's why it's a study of choice. It's definitive. It will tell me where it's at, exactly where it's at, how big it is. But 99% of the time, your chest x-ray is all you're going to need. And you'll never jump straight to a CT without getting a chest x-ray first. Okay, so how do we recognize it? Well, some of the things we already kind of looked at, right? Same thing with like the atelectasis and stuff. The area of concern is more opaque than all the surrounding lung. It's more radio opaque, it's brighter, it's more gray, it stands out. I'm like, hey, this should be dark. It's not, and the surrounding lung tissue is dark. So that's kind of how it stands out. It can be fluffy and indistinct, right? We talked about that alveolar space disease. A lot of times that's what the pneumonia is, the alveolar space disease. So it has that fluffy kind of appearance, except for when it doesn't, and it's interstitial pneumonia. Right? Most of your pneumonias are going to be that fluffy appearance, and it's going to stand out. We'll look at a couple of pneumonias that are specific to a particular type of patient population and why they look different and how they look different. Okay. Usually homogeneous in density, so that's the radio opaque area, can produce those air bronchograms that we talked about. Why? Because it's the fluid and the inflammation within those alveolar space areas, so it kind of does that background to some of those bronchioles so they can stand out. They don't always produce air bronchograms, but they absolutely can. Okay? You can have atelectasis in the affected portion of the lung. Why do we think a pneumonia can come with an atelectasis? Obstruction, right? Multiple reasons for obstruction. Inflammation thickens the tissue, maybe closes off some of those airways a little bit, causing the atelectasis. Fluid buildup, extra surfactant, something can block it that way. Mucus, right? There's lots of different ways that can cause those small obstructions. So pneumonias can lead to an atelectasis. Okay, you can absolutely have both. Good. How do we localize it? We use the PA to determine what lung the pneumonia is in, left or right, and then we use our lateral to figure out which lobe it's in, based off of left or right. Okay? If you can't get a lateral, then what are we using to make a guess? The chart, which describes the locations of the silhouette sign, right? Good. Right? If you can't get a lateral, use your silhouette sign to make your best educated guess. Oh look, it's the chart again. There you go. Okay. Different patterns, right? Lobular, segmental, interstitial, round, cavitary. We're going to look at these different pneumonias and kind of see what they look like. The consolidation caused by the inflammatory exudate, right? Consolidation is in quotes because it's a term for a consolidation of fluid or an area. A lot of times you'll see this with your, in fact, this is more your chemical. So aspiration of chemicals sometimes can have it. You'll see it sometimes where people are, like the cleaners that are inhaling a lot of chemicals can cause a pneumonia. They didn't actually like aspirate the liquid chemical, but the fumes can cause an inflammatory exudate and cause a pneumonia that way. So that gets back into your social history, like, hey, what do you do for work? What's your job, right? That kind of thing. Because there's like no sick contacts, you haven't been anywhere, they're not immunocompromised. Like, why did you get this? Oh, you find out they're a house cleaner and it's the 2 weeks prior to Thanksgiving and they've just been hit with work, which is good, but at the same time they've been inhaling more fumes than they're used to. It can cause potentially a pneumonia. So that's where that social history kind of comes into play. Okay. We're going to go over the pictures, okay? But here's a worded chart for those who like to read kind of the descriptors instead of just looking at the pictures to help you get a better understanding. All right, I'm not going to read that to you. That's for you if you want to use it that way. But we're going to hit a lot of these in the pictures right here. So here's our lobar. Okay? Lobar pneumonia Lobar means, or lobular, lobar means in a lobe, right? It's picking a lobe, and it's usually within that lobe. So strep pneumoniae is your main organism, all right? CAP, for those that don't know what that is, that's community acquired pneumonia. So 90% of these things are these things that people get when they're outside, out at Disney World, Disneyland, whatever, they got sick in the plane, it's community acquired pneumonia, okay? Sometimes these guys can have some real sharply demarcated lines because they sit in a lobe. So if the pneumonia is right on the fissure, you might see like patchy kind of area, and then all of a sudden like this like nice clear-cut line. You're like, well, why is it patchy and demarcated on a different side? Well, that's because it's sitting down near one of those fissures. It's in that lobe, and it just happens to be right along the fissure, and that's why you might see that line. So it's not abnormal to get a sharply demarcated line when it's right up against one of those fissures. Okay. When it's not bound by the fissure, which is a lot of them, that's where the whole thing has those fluffy, indistinct margins, like that alveolar space disease, okay? Silhouette sign or bronchograms like we covered. So you can see here, like I kind of make the right atrium, but I can't, the spine in that area there. So maybe right middle lobe, but I want that lateral to confirm it. But you see the, bless you, you see the patchy radial opaque compared to the surrounding tissue, right? Look above and below. Above and below, definitely a different level of density. Fever, cough, sometimes productive, sometimes not, but definitely fever and chills. This is an infection. Here's your segmental. Most commonly, Staph aureus. Possibly Pseudomonas is just for your wherewithal, for you to know that it can be another organism. Staph aureus is the one I want you to think of these from my course. Okay? All the borders are going to be fluffy and indistinct. There's no air bronchograms because this is segmental. This is within the bronchi. So because the inflammation is now within the bronchi, I'm not going to have an air bronchogram because the buildup is within the bronchi. So these bronchi is where we can fill with the exudates, the inflammation causing that obstructive atelectasis. Okay, it almost looks like the branches of the tree are all inflamed. It's not just in a lobe, but it's definitely a radiopaque area compared to the surrounding lung tissue. All right. Interstitial. The best way for me to describe the interstitial pneumonia is the x-ray, and it always is going to look like this, and then you're not going to see it very often because of the types of patients that this affects. You're almost always going to, it looks like somebody took a handful of sand, threw it on my x-ray, or threw it on the chest of the patient, and took an x-ray, right? Super grainy throughout all of the interstitium. Your guy is going to be your PCP, your pneumocystis carinii durophagy, blah, 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 I can't say that one. But this is your immunocompromised patients, okay? This is something that we typically, healthy people, the immune system is going to be able to fight that guy off and not necessarily cause this pneumonia. Why do I say this? If you have a patient who's not immunocompromised, and you see an x-ray like this, it's time for you to start going, why do we have an interstitial pneumonia? I need to make sure that there's not something going on causing you to be immunocompromised. Also, if you know you have a patient who has HIV or AIDS, right, knowing that this could be their pneumonia. This is normal for them. What's another more common, not necessarily illness, patient history thing that would lead you to believe that they could be immunocompromised? So cancer, let's say they have no disease processes. They're not comorbid, they're not risky. Okay, let's say they haven't had a transplant. I like this. we're missing something. What is a part of our body that if we don't have, we're off? Spleen, right? And I'm playing guess what? I know it's trying to. There's no good way to ask that without giving you the answer. So I'm trying to get you to think about it. Splenectomies. Asplenic patients automatically must always be treated as immunocompromised patients, right? Now the good news is, over the past 15 or 20 years, they've changed the way we do medical charting, and if it was already reported, it should be this big warning banner whenever you pull up that patient in your chart, your electronic health system, that says, patient is asplenic. So before you even walk into the room, you should already know this, assuming it's reported appropriately. If it doesn't get reported and nobody knows, then it won't do that, right? But asplenic patients are considered immunocompromised. So that's always a good question to ask the patient. If you get an x-ray like this and they're not HIV/AIDS, right? They're not on chemotherapy because they're fighting cancer off, or any of your main things that would make immunocompromised, you have your spleen. Good to ask that. But anyways, this would be the only one here. Again, grainy, looks like you took a pile of sand and threw it on the x-ray. That's your interstitial pneumonia concern for immunocompromised patients. Round pneumonia. Children, kids, right? Mostly in kids. H-flu is your more common organism, which means hopefully we don't see a whole lot of it because hopefully they have their immunizations. We don't have to worry about it. But it sounds like a lot of people are getting less and less immunizations now. I just saw a thing on the news today that they had like 1,300 measles cases in the country. And like immunization rates have gone down by like 5.5% across the country. So, yeah. I know the CDC keeps calling me to do a survey on if my kids are immunized. I keep ignoring it. Look at their medical records. It's fine. All right. But yeah, so H-flu. So I say that to say like H-flu is, so I got to ask that question. Are they at the end of their immunizations? All right. So the key thing with the round pneumonia, what I like about it, is it's almost always posterior in nature when you end up getting your lateral chest x-ray. It's almost always posterior in nature, typically in the lower lobes. Okay? As you'll see when we go into it, it can be mistaken for a lung tumor. Very commonly. How many kids have giant lung tumors? Not many, right? Most lung cancers or tumors are from either primary from like smoking for long periods of time. Hopefully this 7-year-old hasn't been smoking his whole life or her whole life. Or metastases from other ones. And when you look at a lot of those other lung metastases, if you go back to that one chart, right, where they're like the prostate, the breast, the testicular cancer, again, ones that are typically in patients when they get older. So there's not a whole lot of lung tumors in children. So, and especially if you find out they're not up to date on their H-flu vaccinations, you're thinking around pneumonia. Cavitary tuberculosis. That's got nothing more to say about that. Cavitary tuberculosis. The difference, though, that you can tell on this is what I like is you have your thickened walls around, and you have the cavity in the center. So I want you to take a good look at this and kind of get an idea and realize that how thick the walls are. So what happens is we get the tuberculosis, the body and the immune system wants to try to fight it off. They wall it off to try to protect the rest of the body from the TB, and we end up with this cavitary pneumonia here. Super thick wall. Notice how it's not necessarily fluffy and indistinct. Like I can circle where that cavitary pneumonia is, right? This right here, there it is. I got some inflammation down here connecting to it, but there's my cavitary pneumonia. Okay? A lot of times in the upper lobe, that is upper lobe. If you remember how our left, it overlaps a lot in the center. Your lateral will help confirm that. It's not always hiding up in the apices, right? A lot of times it's in the upper lobe. Thick wall, smooth margins, no air fluid levels. Do you notice how we don't see any air fluid levels? I don't have a nice little line of fluid sitting in this cavity, right? That'll become important later when we start looking at cysts in the lungs. And how do I tell the difference between something that looks like a cyst and something that's a cavitary or cavitary pneumonia or a cavity? Cysts have air fluid levels, cavities do not. but their outer walls and stuff are going to look very similar. It's just a matter of is there fluid in there or not. Aspiration pneumonia, there's all those causes. Really, anything that ends up in the airways that's not supposed to be there, which is basically any liquid possible, can cause an aspiration pneumonia, right? So why altered mental status and neurological disorders is that aspiration pneumonia? Because depending what's going on, if I'm having an issue swallowing, drinking, or anything along those lines, and it goes down into my airways, that can cause an aspiration pneumonia. It's not the stroke. The stroke doesn't cause the pneumonia. It's the lack of being able to control my bodily functions and be able to swallow well and make sure I swallow everything down and not breathe stuff in that can cause the aspiration pneumonia. Same thing with anesthesia drug overdose. You know how like when you go to the dentist afterwards, you guys do the thing and they're like, hey, don't eat or drink for like 2 hours because you're still numbed up. It's not because they're worried if like you're going to do anything bad. They're worried that you're either going to bite your tongue because you can't feel it and you won't realize it, or they're worried that you'll actually aspirate things because you might still be numb in the back of your throat and not be able to properly control your epiglottis and swallow appropriately. That's the reason they give you that. That's the same concept with the anesthesia and the drug overdose, is losing full control of those areas. GERD goes without saying, reflux comes up, goes back down. Post-op for head and neck procedures, most common complication of the barium swallow study, again, things we're drinking and go down into the airway. There's what it can look like. This is the barium, so it stands out a lot better, right? But most of our aspirations are going to go on the right side because as we looked at, that right bronchi is more vertical. It's a lot easier for that stuff to get through. And then it's going to kind of branch out like that little Christmas tree, and you're going to get the pneumonia typically just right in this area. Yes, it can happen on the left, right? But same thing, it would be in the left bronchus, which would be a little bit higher, and it would be kind of right here if we were having it. But risk of aspiration pneumonia right there. Barium is going to be your most common complication of the barium swallow study. Here's one of those instances where a CT would come in handy because I have an aspiration pneumonia and I want to know how involved it is. I want to know how involved it is. So this is where that CT can really break down, and you can see posteriorly we definitely got quite a bit. It's going almost all the way anterior. But then when I look at my left lung, maybe not all the way anterior on this slice, right? So this will give you a good idea of how severe it is, how involved it is. Are you guys going to be doing it in an outpatient setting? Probably not. But a lot of times if a patient has an aspiration pneumonia like this, they're probably going to be admitted for observation just to make sure, especially when it's barium, because that's not water soluble, right? So we're concerned about how long that's going to sit in the airways. So that while they're inpatient, they will likely end up ordering a CT to see how involved it is so they can kind of track it as they get better. Yeah, I don't know. I don't think I made a note of what the patient history was on that. So yeah, that could be a drowning patient that aspirated. It's a good call. I don't know that answer. I didn't get the history on this one. All right. We talked about atelectasis, we talked about pneumonias, we talked about pleural effusions, we talked about all those things. What happens when we have an entire opacified hemithorax? It can be any of these things that we've talked about. It could be an atelectasis of the whole lung. It could be a massive pleural effusion. If you're going to have that, usually it's trauma or some type of malignancy like a cancer or something. You can have a pneumonia of the entire lung. That can happen in your really sick patients. And last but not least, don't forget, they could have their lung removed. Post-pneumonectomy. Okay? Doesn't happen very often, but it should be in your surgical history. The key thing with that is about 4 months after they have it done, you'll get that, it'll look like a fully opacified lung area. You'll see surgical clips, but we'll take a look at that and what that looks like. All those things I told you about with the entire lung. What pushes, what pulls. Here's a nice little chart to break it down for you. We haven't talked about tension pneumothorax yet. We will. Okay? So for now, atelectasis, pulling things towards the affected lung. Massive pleural effusion, fluid, pushing things away from the affected lung. Look at those mediastinal structures. Pneumonia in the entire lung, no shift. Plus, they're pretty dang sick. We don't have fever and chills. Post-pneumonectomy, a little bit trickier, right? So know that initially they're going to shift away from the opacification because you just had the surgery, so you got fluid accumulation there, so it's going to push, okay? And then the lung's not there anymore, so once that fluid kind of goes away, that vacuum's going to pull it just a little bit, right? Because now there's this space there. So it'll push and then pull. Still super, super rare. There are not a whole lot of patients out there who have had entire lungs removed. But we'll talk about tension next block. But this is going to help you decide when you have an entire opacified lung like this, what's going on. So here are multiple cases. So, upper left-hand corner, where it says AP erect and it has the right marker. What's causing that opacified hemithorax? Atelectasis. Look at the pulling of my trachea and my carina and the bronchi. That should be right down the center here. That is pulling it over. Look at the pulling over there. Good. Good, good. What about the one right below it? Yeah, massive pleural effusion, right? Now I'm pushing this away over to the other side. What's the cause of it? Well, if there's trauma, I'll say trauma. But if there's not any trauma, I'm going to think probably cancer until proven otherwise. Okay? So good. Pushing it away. What about this guy up here? What's causing this entire opacified lung? What do we think? So that one's going to be a pneumonia. I have centered structures. They're not being pulled one way or the other. Not being pulled one way or the other. And I kind of got a little air bronchogram kind of going on down over here too. Right? Okay, I can see the main bronchi, but then look at all the little guys. Look at all the tree branches I see. So there's my air bronchogram as well. What's going on the other one? I don't know. I don't know. I don't know. It's in there. I don't have any other. The thing with this one, right? So this is showing you that we could have multiple things, right? So I see the air bronchograms. That makes me think pneumonia, right? But now it looks like my mediastinal structures in my trachea are shifting, but both lungs are opacified. So is it pulling? Is it pushing? Just off of the image, I have no idea. I have no idea. Right? So I put this one in here to again reiterate the fact that an image by itself is not all the time useful. It's going to be adjunct into stuff that you're doing. Now, if I give you most likely choices on just an image for these three, right? And the choices are atelectasis, pneumonia, massive pleural effusion, and I make up two things that aren't opacified hemithoraxes because those are the only three ones we really talked about, right? Then you have enough here to make a most likely educated guess. But this one here with just the image, okay. Got these now in the blue slides. You notice how this is not a blue slide, right? So when you go to your review, this one will be on a blue slide. It's that same hemithorax one. And for somebody had asked, when you're looking at the notes, if you see 2/2, that means secondary. So for anybody who's just curious on the shorthand, right? Because in the notes it'll tell you that there's a large pleural effusion, 2/2 bronchogenic carcinoma, secondary to the bronchogenic carcinoma. So they got the bronchoduodenal carcinoma causing the massive pleural effusion. Questions on the effusions, the pneumonias, the atelectasis, whatever those things, the shifting, the pulling, right? Lots of clues in there based off of what we're looking at. If you know what normal is and you know where anatomy is supposed to be, lots of clues to lead you down which one could be going on. All right, just because we have a good stop, let's go ahead and take 10 and come back at 3. Chest X-ray pathology. All right. What's my initial study on almost everything? Chest X-ray. All right. The notes. I want to rehash this. I hit it in the first block too. I hit it in the first block as well. I'm going to say it again here. I pull nothing from the notes for my test. The notes are there as reminders for myself during the lecture sometimes, or they're more detailed from questions I've been asked to have in there in case those questions get asked again and to give a deeper understanding. Now, all my stuff is pulled from the slides. If there's something that's in my notes and on the slide, well, it's in the slide. That counts, right? But there is no factoids, there is no descriptors, there is nothing that's in the notes that's not in the slides that I pull for my exam. So when you're talking about brain power and where do I focus my efforts, you do not need to spend time trying to memorize little things in the notes if it's not on the slides. I'm going to say that again for this block in particular, because some of those notes on some of these slides, for those of you that are using PowerPoint and haven't converted it to PDF, they can be kind of lengthy. I'm not pulling from there, all right? So if you have any specific questions about it, let me know, but all my stuff is in the slides, or we talk about it, or it's in the pictures, that kind of thing. All right. Bunch of cancer pictures. You want to guess what we're going to talk about in this lecture? The answer is one of many things. This cartoon here is why you have to look at all your stuff. Right? Make sure you annotate all that stuff. Again, yes, you'll have a radiologist, right? And really, when I say that is, when you read it and you give a wet read on stuff, when you're looking at things, you can be wrong. You can be wrong. That's okay. It's okay, because at your skill level, you're like, hey, this is what I think I see. This is how I'm going to act. As long as you remember to go back and look at the official read from the radiologist and adjust your plan of care accordingly if you were wrong, right? Doing the ret read does not absolve you of checking the report from the actual radiologist, because their job is to notify you what's going on. It's your job to read that report and adjust course if you need to, okay? Or call them and say, hey, you said this was normal, I see this, what is it? They're like, oh man, that's just a vessel. That's not a parabronchial cuffing, that's just a vessel, that's fine, right? Very rarely, I told you I've called radiologists before for abnormalities that they've missed. Almost all of that was MSK stuff. Almost all of that was fractures. Very rare, I can't think of any time I've actually called on like a chest x-ray or something along those lines. Because of this cartoon, they look at those things with a fine-tooth comb. Because you know your stepwise process, they have to do it too. And if they miss something, right, and you didn't see it, they're the expert, they missed it, you went off with their report, you're like, I didn't see anything, they said there was nothing there, we're good, and then something happens, that litigation comes back to them, not you guys. So chest x-rays, they take it should take everything seriously, but they take chest x-rays even more seriously because there's a lot that can be going on there. So you can be wrong, that's okay. Just make sure you look at that report and adjust fire if you are. All right, more airway stuff. Whew. Pneumothorax, subcutaneous emphysema, nodules and masses, that's our cancers, and towards the end, our thromboembolic disease, so we're finally going to get into looking at PEs, okay? We just spent the last 3 hours or so looking at different fluid abnormalities, right? Or radiopaque abnormalities on the chest. Now we're going to shift, and we're going to find absence of lung tissue. We're going to talk about the pneumothorax. Okay? We call it pneumothorax. We'll learn a little. This is partially with the point of care ultrasound, with the EPAS we can do as well. We'll go through all that. What is a pneumothorax? So we talk about pleural effusion when there's too much fluid in the pleural space. This is when air enters the pleural space, right? Pneumo, air, thorax, thorax. More specifically, the pleural space. All right. Typically, what ends up happening is the parietal pleura stays where it's supposed to, and the visceral pleura retracts. So when we're seeing the thin white line on the X-ray, when we start looking at it, you're actually looking at the visceral pleura edge. The parietal pleura is still in the thorax, and it's air within those. Because of that, that line is going to follow the natural curvature of the thorax because it's a layer of the pleura, right? So it doesn't go in weird directions. It's always going to be in that natural curvature of the thorax, and we'll see what that looks like. You're likely going to have an absence of lung markings or vasculature. We've seen all the lung tissue, how it has all the vasculature with kind of a grayish area, and we see the vessels and everything. Well, guess what? If the visceral pleura is pushed in, and now my lung is pushed in, I've got nothing. It's going to be all black with maybe some rim, right? But there's going to be no lung markings because I have no vasculature because the lung has been pushed in due to the air in the pleural space. And we'll see what that looks like. If you have fluid and air in there, we saw that one picture, it's a hydropneumothorax because I have both, okay? And then we'll talk about that deep sulcus sign in a supine position. So if they're laying down instead of standing up, how that kind of presents itself so you have an idea what that looks like. Pathophys. Here's your slide with all your stuff in pneumothorax. Air enters the pleural space. How? Usually trauma. Not always trauma, but usually trauma. Okay? Tension pneumothorax, we'll talk more about that. That's when we have a pneumothorax that then starts to compress the lung tissue, starts affecting the cardiac output, the heart, the vessels, the mediastinum. We get what's called a tension pneumothorax. That becomes an emergency. We're going to talk about how we can see that on X-ray, but then we're also going to talk about how we truly diagnose that. Okay? What are your symptoms? Oh, chest pain, shortness of breath, dyspnea, hair hunger, or no symptoms. Great. X-ray is my initial study, okay? Upright and expiratory films are preferred. You're rarely going to get an expiratory film. I would say the reason you would get an expiratory film, when we talk about where you blow all that breath out and then take one, is if you were like, man, I really feel like they have a pneumothorax here. I did my X-ray, I don't see it. Before I jump to my CT, because it's so much radiation, let me go ahead and get an expiratory film and see if I can see it. Because when you breathe in, right, you have all that pressure, the lungs are pushing on that pleural space, you'll see that pneumothorax, but when you push everything out, you don't have that pressure anymore, right? All the air is out of your lungs, or most of it is out of your lungs, so now that air in that pleural space that's not supposed to be there has more of a chance of pushing on the lungs, and it'll stand out a little bit more on that expiratory film because the pressure will be greater on the outside of the lungs. So if you ever have that patient and you're like, I really think this is pneumothorax, but the X-ray is not confident, order your expiratory films because that will help it pop a whole lot more. Okay. If it's trauma, your X-ray is going to be supine, right? We know it's going to be unreliable, which is why we'll talk about that deep sulcus sign in case you see it. If they are, you can do on the FAST exam if they're unstable, right? You can do an ultrasound. We briefly looked at that last block, but we're going to give you the tools now, like you knew, hey, lung sliding, M mode, ultrasound, great. Now I'm going to show you what normal versus abnormal looks like. So when you do these in your EFAST, you'll be able to tell if it's abnormal or not. And CT, again, is your study of choice. Why? Because the detail of the CT, even if it's like a super small pneumo, like right at the edge, the CT will pull this out. Okay? So if you do your expiratory films, if you still think it's a pneumothorax and it's not obvious on the X-ray, CT would be your study of choice, assuming they are what? Stable. Not sending unstable patients to CT. That's what the EFAST and ultrasound is for. All right. So what does it look like? We already talked about the visceral pleural line and the convex curvature. We'll look at those pictures. Absence of lung markings, I mentioned it already, and the deep sulcus sign. This is just a review slide from what I said.
right? It's all those things right in there. What causes them? Most common cause? Trauma. Trauma. Right? You can have spontaneous pneumothorax, right? Trauma is still the most common cause of pneumothoraces, even though spontaneous is common. Trauma is still the most common cause. When you think it's spontaneous pneumo, tall, thin males between 20 and 40, right? Why men over women? I don't know. But tall, thin males between 20 and 40 get spontaneous pneumos all the time. Remember this, for those of you that on your OSCE get the 20-year-old or 18-year-old Army person that is hypoxic and tachypnic and tachycardic and can't breathe. It's not asthma. It's probably a spontaneous pneumo. Okay? Don't send them home. They're hypoxic. That's bad. All right. Anyways. Other diseases can cause it, right? Fibrotic disease, rupture of an alveoli. Anything that can put air in the pleural space can cause it. So if you think about it, we talk about trauma. Why is trauma the most common? Well, because if I have trauma and I get stabbed or take blunt force trauma or something, the blunt force could break a rib, which could puncture a lung. Or if there's actual penetrating trauma, that's bringing air from the outside into that pleural cavity. Okay, pathophysiologically, that kind of makes sense. It can happen the other way around too. If you have an alveolar sac, if somebody with COPD, emphysema, asthma, that takes too much pressure and it bursts, I've now brought air from inside the lungs into my pleural cavity. It just happened internally, causing a pneumothorax. So anything that gets air into the pleural cavity can cause it. You just got your most common right there. So your couple of types is primary and secondary, okay? Secondary is when it comes from a disease process like emphysema or asthma or something along those lines. Primary is going to be spontaneous, but the biggest thing is simple versus tension. This is what I really need you to know. I'm not so much concerned about primary versus secondary. You need to know how to see pneumothoraces, you need to know how to diagnose pneumothoraces, but you need to know simple versus tension. So on X-ray, simple pneumothorax is I see a pneumothorax and there's no shift to the mediastinal structures. There's no shift to the mediastinal structures. Tension on X-ray, we have a shift to the structures pushing away from the pneumothorax. Again, it's like the fluid, right? There's pressure pushing away. So if I have a right-sided pneumothorax, my mediastinal structures, if it's tension, are going to shift to the left because of the pressure pushing in on that mediastinum. Well, I want to be very clear on this. That is a late radiographic finding. Okay? That is a late radiographic finding. We do not rely on X-rays to make the diagnosis for tension pneumothorax. We do that clinically. You don't need an X-ray to make that diagnosis. We do it clinically. Or if you get an X-ray and there's no mediastinal shift and we see a pneumothorax, but the patient is unstable, it's a tension, even though the mediastinum hasn't shifted yet, because it's causing cardiovascular compromise. We'll talk about it more when we look at it. It's all based off of the patient's vitals. If I have a pneumothorax and the patient's vitals are showing hemodynamic compromise, it's a tension pneumothorax, period. Does not matter if the mediastinum has shifted yet or not. If I have a patient who has a pneumothorax and the mediastinum has shifted, but they're stable, I'm still calling that a tension pneumothorax because it's not going to be long before they become unstable. So if you have the shift, you can call it tension even though the patient seems to be doing okay. But if you don't have a shift and they're not doing well and there's a pneumothorax, it's tension even though there's no shift. Can't stress that enough. Okay, let's look at these. One on the left is normal. I want to draw your attention, not to the blue arrows, but to the similar area on the normal. Look closely at my lung markings. They're subtle, but you see the little gray lines that come almost all the way out to the edge of the thorax wall. Now, when I have my pneumothorax, follow your blue arrows. A, look at my thin white line. that comes down, follows the curvature of the thorax, and then lateral to it, I have nothing. I have no lung markings. It's just rib and black. That's your sign for the pneumothorax. I have my white line that follows the shape of the thorax, and I can see all my lung markings, and they stop at that white line, and I have nothing past it. That white line again is that visceral pleura being pushed because air got in between the parietal and the visceral pleura. I don't have a mediastinal shift yet, so we would call this a simple pneumothorax, assuming my vitals were normal. Which means if I give you a pneumothorax without a mediastinal shift, and I want you to tell me if it's simple or tension, you need vitals. You need vitals. Now, if I wanted you to just have the x-ray and not decide between simple or tension and just ask you to identify pneumothorax, you don't need vitals because you're just finding pneumothorax. I'm not asking you to differentiate between the two. Okay, so take a minute, look at these guys with what we just kind of went over, see if you can find them, if any. I love to give normal chest x-rays. These are two separate images, as it says, two separate patients. Okay, so these do not necessarily go together. I'll give you a few seconds to kind of look at it and see if you can pinpoint if there's an abnormality, where it is, and what's going on. You still looking, that's okay. All right. So let's go with the first image on the left. I'm just going to point it out. You tell me, you do in your own head whether or not you saw it. We have a left-sided pneumothorax right here. Right here. All right, I got my visceral line in the shape of the thorax. I have absolutely no lung markings lateral to that line. Yes, sir?
The left costrophrenic angle, is that the deep sulcus sign?
Yeah, good question. It is not.
Okay.
It is not. There is definitely some blunting in this costrophrenic angle, okay, which tells me maybe this was a trauma, and that some blood or fluid starting to build up on that side. And you'll see why that's not when we actually get to the deep sulcus. Yeah. All right. So that was my left pneumothorax there. Now, on the image on the right. Yeah, oh yeah. Right here? Yeah. Yeah. But what was the trauma, right? I don't know, like was it a stab? Was it what was going on? What caused what? But yes, there is trauma. For those that were looking at the rib fractures up here, that is the trauma. I would need to know, and I don't know with this picture, what was the mechanism of action to know was the pneumothorax caused by a weapon in the actual penetrating trauma, or was this a blunt and maybe the rib kind of punctured the lung, that kind of thing. I don't know that answer. But yes, that is the trauma. Now, on the right side, right here. On this side here, follow it up right there. Kind of comes in. Does everybody see it on the right side? No lung markings up here. None. There's my visceral pleura, and I come up, got plenty of lung markings on the inside. No lung markings. Are they all going to be this big and stand out like this? No, they're not. Will they be like that on the test? I don't know yet. I haven't picked the pictures. Sometimes. Yeah. Put it in, what do they call that? Put it out in the universe? Like, yeah, absolutely. Yes, ma'am.
On the left side,
This one?
Yeah, does that also have because of the line that you have right?
So say that again on the right lung, on the left picture.
This line it has running through here.
This guy here.
No, on the corner. Going up one line on the outside of that. A
No.
little bit to the.
She's talking about like the dark or something.
The left.
Oh, this.
Like right there, sir.
This. Yes, I was getting there. Yes. No, I'm glad you asked. I was getting there. That was my next point. What is that? I'll just do it now. That's the scapular border edge. Right? That's the edge of that's the medial scapular border. So, I don't really see it on this one. What's the difference? The difference is the patient standing like this, or did they roll their shoulders forward to get those scapula out of the way? So how can I figure out, is that a pneumothoracic line, or is that a scapular edge? There are a couple of different ways. One, the first thing, I can see lung markings still superimposing over that part of the scapula. So unlikely going to be a pneumothorax, because I can see the lung markings. Two, my line doesn't shape all the way up like the pneumothorax and follow the thoracic wall. It's kind of just like from here and this straight vertical. But what I like to use, for me, that really kind of clarifies it, is I follow the scapula. I see the outer part of the scapula here, and I trace it down, up and over. If I can trace it, kind of like when we did the MSK stuff, you trace your cortex. If I can trace the full scapula, and it looks like the way a scapula is supposed to look, that's how I recognize that it's a scapular edge. So I do the tracing first, and then confirm it with lung markings superimposed to go, oh yeah, that's my scapular edge line. Yes, sir.
On the right picture,
Yes.
Is she rotated, or is there trauma?
She is a little, I would say, probably a little slightly rotated.
Because I can get that rib fracture right above it.
Got the rib fracture above it, but what I got here is I have the gap here, and then if you look at the head of my clavicle, it does come into the spine a little bit. So I would call that some rotation here. So we got a gap here, and then this clavicle one looks like it's coming into the spine, so I would call that slightly rotated. You will see that a lot in trauma, because trying to get the patient positioned perfectly for an x-ray, it's really difficult to do. Yeah?
Does any, like, to the right picture,
Yeah.
the gastric ball, does that have anything to do with the chest?
It does not. So this is just part of your large intestine. This is going to be part of your splenic flexure that comes up. We haven't talked about abdomen yet, but that's what that is. Yeah. No, good. So I like this. You guys are seeing things and you're like, hey, this looks abnormal. So even though I'm asking you to look for pneumothoraces, you're going through your stepwise process. Call out those things that look funky to you so we can talk about it. Yes, sir.
Sir, does the pneumothorax, does it always follow the entire course of the lung from top to bottom? Or would it just be like the top half, you can see that space?
Yeah, good question. So no, it does not always follow the course of the entire lung and the entire thorax. Depends how severe it is. It will always have the generalized shape of the thorax, but it could just be this portion here, right? So absolutely, it can just be a superior portion and working its way down. It does not have to be the entire thorax or the entire lung. A lot of your spontaneous ones, especially when you catch them early on, are going to be like just the superior portion, right? Because what happens when I have a spontaneous? Well, air rises, right? Because the gravity is going to sit up there. So a lot of times that's where it starts. And then even on this patient here, you can kind of see her scapular edge. Yeah, no, she did a great job. You can see a little bit of scapula kind of right in there, but for the most part, her scapula and a little bit kind of here. See that little superimposed line that kind of goes over the ribs and comes down? So you got your pneumothorax, but then I still got this other radio-opaque line. That's that scapular edge. I'm going to do it on this side too so you guys can see what I'm talking about. So we got our pneumothorax here, right? But then when I trace my scapula down and kind of come around, I got this extra little kind of superimposition line that goes along with my scapula in the medial border, up and down, kind of superimposed on that rib there. Right? So she did a much better job of bringing her shoulders forward to get those out of there, but those are your ways to determine between a pneumothoracic line or a scapular line. A trace, then look for lung markings. That's the order I would do it in. Okay. here's an example of your inspiration versus your expiration. The center one is an inverted image. You can do this on your like your digital machines or whatever. It's not a great X-ray because you can't really get any diagnoses off of it. Sometimes people will use it because it makes the lungs brighter to try to pull out a small pneumothorax. I say just do the expiratory films. It's more valid, right? So when I take my first one up here, my inspiratory, okay, and I look at it, I got it. This one's kind of blocked off with this little temp indicator. Sorry, guys. Right up in here. Right lung, right up in here. Kind of hard to see. Okay? But now look what happens when I get my expiratory film. Look at how big that pneumothorax becomes. Right? Again, why? Because there's no pressure in the lungs now. There's no outward pressure pushing the lung tissue out. When they take a deep breath in, it's going to go right back to this. That's fine, that's good. Air, the lung is able to get out. But you can see why that expiratory film really makes that pneumothorax pop, because the pressure changes and now that lung tissue just gets shoved down and kind of pushed. Not causing any major pathophysiologically issues with that, because you're exhaled anyways. The lung is going to be smaller. And then when you breathe in, you get back to this area here. Ooh. So that's just kind of showing you where those expiratory films could come in. So if I end up having a patient that I suspect of pneumothorax, and I can't really tell if I can see it or not, we can do an expiratory film just to kind of verify and see if I'm missing something or not.
Does that center one have any?
The center one? No. Yeah. Right? Because if I'm looking at mediastinal structures, my trachea is where it's supposed to be. This is my right atrium, right? The heart, it kind of pops a little bit more when you kind of invert it, but this doesn't look like it's shifted one way or the other from a mediastinal standpoint. And then even if it was, right, this patient has a pneumothorax on the right side, so we would need pushing over to the left, right? Because it pushes it over. Oh, you said tension, though.
Oh, I'm sorry, I meant pneumo.
Okay, yes, there's a pneumo. It's not tension. Yeah,
Sorry.
that's okay. Yes, there is that same pneumo, right? It's right here, just inverted. So yes, there's a pneumothorax. It's not tension.
Yes.
Okay.
Worse me things.
So yes, you see the pneumo. That's good. There is one there. Now, here's where we start to have radiographic findings of our tension. First, do you see the pneumo? The white arrows, right? Now I go, okay, there's my pneumothorax, that we know, and now I'm like, well, where's my heart? Like, it's almost all pushed over here. Like, I can't see any of the heart. Everything's being shifted over, so I can't make that out. There's depression of the left hemidiaphragm a little bit. That's a little bit of an advanced finding, right? When you guys are like seeing these more often, but you can see how like there's maybe, I would say, half a vertebrae difference on my normal from my right to my left hemidiaphragm. Like here, I probably got a vertebrae and a half difference, and that's kind of how I look for the depression, is I know it should be about a half a vertebrae. So if it's more, I use the vertebrae to kind of help figure that out. So we got the depression, we got the pushing of the mediastinal structures. That in turn is going to make this a tension pneumothorax. What's the treatment for this? Chest tube. What about needle decompression? Temporary, very temporary, right? Until you can get a chest tube available. Needle D is never the definitive treatment for these things. So if you're in a hospital, just put the dang chest tube in. You guys are going to do that again. We already talked about that. Okay, so here's another tension one. You wanted your deep sulcus sign? There it is. Right? Supine x-ray, deep sulcus sign, well down into the abdomen. That's what the deep sulcus sign looks like. Looks like the left lung is almost an entire third larger than the other lung, right? Where the pneumothorax is. Why is that? I'm supine, the air can't just go up, so it kind of spreads out, pushes things all over the place. We get the deep sulcus sign on the supine x-ray. Sometimes you may even see what they inversion of the hemidiaphragm. So instead of it being like the hill, it's flipped out, right? Again, because it's supine and that air, that pressure is pushing it down, it just kind of inverts it temporarily. They stand back up, it'll go back to the way it needs to because the air will rise, right? The hemidiaphragm will come back. But just temporarily while they're supine, it can't push it down and cause that inversion as part of that deep sulcus sign. So the key thing on this, again, is shifting the structures away. We have the pneumothorax. I don't need vitals to determine that it's tension because I have the shift. But if I didn't have a shift, vitals would tell me simple versus tension. This poor little lung. Here's what a pneumothorax looks like on CT. Okay. So now you can see here why CT would be a, basically a study of choice, because look at how well it stands out against the thorax wall, and you can really see that lung tissue. So even if I had an itty bitty pneumothorax right here, I would see that nice black circle, or that nice little black area on the CT that maybe I can't pull on an x-ray. So this is why we'll do a CT as a study of choice. We don't do them often for pneumothoraces, because a lot of them can be seen on x-ray, or when they get bad enough, we just treat it as a tension when it comes in. Watch your eyes. It's red for a reason. How do we diagnose atelectasis? With an x-ray. How do we diagnose pneumonia? X-ray and symptoms, right? When we get to it, how do we diagnose a PE? With a CT with contrast. How do we diagnose a tension pneumothorax? Clinically. Clinically. Okay? Now this one is not about the pneumothorax. This is where we got, some people like we got high flyers, which is good, right? We talk about things that look like pneumothoraces that aren't. I'll skip over the scapular line because we just talked about that. The medial border of the scapula. Looks like a pneumothorax, but isn't. Here are some other things. In that top picture, right, are my bullae, which we haven't talked about yet, but we will, okay? Bullae or blebs or cysts or things that cause the loss of lung markings, right? There's like no lung markings in this guy right here. So you're like, I don't see lung markings, it must be a pneumothorax. It's not. Why is it not? What is the direction of my white radial opaque line? Not with the thorax. What this is this is a bullae, which is basically best way to describe it is like a large air cyst, large air pocket in the lung. Okay, we'll see some other ones that look like this as well. And so because it's this large air pocket, there's so much air in there that it has expanded out. There's not a whole lot of vasculature and a whole lot of lung markings in there at all, because now it's just this big air bubble that's sitting in the lungs. You get this a lot of chronic smokers, things along those lines can cause this. So there is no lung markings or very little, but the key thing is when you don't see the lung markings, look at my edge, look at my radial opaque line. That's not a visceral pleura. It doesn't go in that direction. That's how we know it's not a pneumothorax. Okay? Also, skin folds. Skin folds. So some of you at some point in your career are going to see some very large patients that have way more skin than they should because of their size. It's just the nature of medicine, right? And so when you have a bunch of thick, soft tissue in layers, it can present on an x-ray. It can even present in the shape of a visceral pleura and a pneumothorax sometimes, because of how the skin folds kind of come down on the back or in the front. How do we do that? I see my line that looks like a pneumothorax. Do I have lung markings? Do I have lung markings? If I have lung markings, it's normal. It's not a pneumothorax. It's a multi-step process, because this is in the shape of the thorax. This line that I'm seeing is in the shape of the thorax. Never mind, it's more radial opaque, or sorry, more radiolucent as opposed to radioopaque like the pleura, focus more in, I see that shadow, I see that line, I have lung markings superior and lateral to it, that is not a pneumothorax. But this one, I don't have those lung markings. So I got these side by side so those skin folds don't trip you up. And then we covered the medial border of the scapula already. Size of your pneumothorax. I'm not going to make you measure the size of the pneumothorax, but you need to know when we need to put in a chest tube. Because what's going to happen when you get your reports, radiologists will tell you the size of the pneumothorax. And you can do it too if you see it. You have fun little measuring tools on your thing that you can measure it. I'm not going to make you do that for the exam or anything like that, but in your clinic you can do it, or your radiologist will tell you. Know the 2 centimeter rule. Okay? If the distance between the lung margin and the chest wall at the apex is less than 2 centimeters, you usually don't need a chest tube. That will resolve on its own. It's a general rule. You usually don't need a chest tube. If it's greater than 2 centimeters, we're doing a chest tube. However, if it's less than 2 centimeters and the patient's hypoxic and having chest pain and you have a pneumothorax, are you not going to put the tube in? Put the tube in. Because they're symptomatic, right? So you can justify that, right? They're having a hard time. Maybe they look like they're borderline stable. They're having a difficult time breathing. You take the oxygen off, they still can't put the chest tube in. And then the justification is they were symptomatic. And no joke, it's fun. I like doing chest tubes. Maybe to do them your secret stuff. But most important part, right, is that clinical status. That's why I say that. Same thing with attention. That determines your treatment. But if you're got the guy who's in your clinic and he's stable and he's just having some shortness of breath with activity for some reason, but he's fine right now, you get the x-ray and you see a small spontaneous pneumo, this is the rule you're going to use on whether or not they can just manage it themselves and kind of check in on them, or if we need to admit them to get them a chest tube. All right, pneumothorax using ultrasound. So this is going to kind of break down what the ultrasound looks like. Understand that the ultrasound is more sensitive than radiographs, but CT is still the best study to visualize it. Okay, it's still your study of choice. And this is just kind of showing you some anatomy here. We got the 2 ribs, or the dark area. The 2 ribs. Ribs are always shadowy. Ultrasound doesn't like ribs. Okay. I got my pleural line here. Okay. This picture, don't hang yourself up on memorizing this picture. This is not going to be the diagnostic picture. I'm just giving you an anatomy kind of lesson in that aspect, okay? So we got ribs, we got pleura, and L is probably what? Lung. Okay? There's a YouTube video. This is the one I want you to focus on. What happens is, the reason you need this is because what's going to happen when you're doing your EFAS and you're doing your ultrasound, you are finding this picture, okay? And then when you switch to M mode, you get a little line that lines up, and you have to place that line where you want it to detect the motion. So you want to place that line where the white arrow is in between the ribs so you can get the pleura and the lung, and then you hit M mode. And then what it does is it spans it out, the motion, and it gives you one of these 2 pictures. Okay? If my lung is sliding on the pleura, which is what it's supposed to do, because I have my parietal layer and my visceral layer, and they should be sliding together because the visceral is attached to the lung and the parietal is attached to the thorax, I get my seashore sign. Seashore sign. Sally sells them. It's great. Beach, ocean, sky. Beach, ocean, sky. Use your imagination, right? I got my sandy beach, I got the white cap waves of the shore of the ocean, and this is my stratus clouds in the sky. That is normal. I should see 3 different things: beach, ocean, sky. That means I have movement, That means my pleura are together and there is no pneumothorax. If I get barcode sign, where it just looks like the same across the board, that means it's not detecting motion. That means my parietal layer and my visceral layer are not touching. It can't see the motion. There's air between those. That's a positive pneumothorax. Okay? Barcode sign, positive pneumothorax. Beach, ocean, sky, I'm relaxed. I have a drink in my hand, I'm hanging out because this patient doesn't have a pneumothorax. No worries. Okay? Call me Kenny Chesney. So, that's how you can tell the difference between the two. Any questions on that? You will do them on each other in senior semester, so you'll get to see what this actually looks like. Now, here's the catch. How many places do you think I need to scan to make sure they don't have a pneumothorax? Start and work your way up, right? This is not a one time in between the ribs, because as we saw in the x-ray, what if it's up here, right? And you do here, you're like, no pneumothorax, good job. But in reality, it's 1 or 2 rib spaces up. So what you start is you start a little bit lower, and then you work your way up until you get a positive. Once you get a positive, you can stop, right, if you want to do this. But you're just going to work up, okay? I'll let Dr. Love kind of tell you, or not, Dr. Love does event stuff, and what program's going to do by the time you get there. But I'll let them tell you kind of how far to go. It's going to vary based off the patient, what you can get. But it's not just a one-stop picture. It's you work your way up. Okay. Displacement of the heart and depression of the heavy diaphragm are signs of what type of pneumothorax? Tension. Most important determining factor in whether a chest tube is required. Most important. Clinical status. Clinical status. Right? I don't care about the size if I know they have a pneumothorax and they're sick, they're unstable, they're getting a chest tube. That's way more important than the size. Questions on pneumothoraces? Okay. Sure, this was the boss. All right, let's talk about some pulmonary interstitial emphysema. Okay? So this is going to be when your alveoli have increased pressure and volume. Okay, it can rupture and have extra-alveolar air. This creates a pneumothorax in the peripheries. This is some of those conditions I told you about where the alveoli rupture, present air into the pleura, and then creates a pneumothorax. Okay? A lot of times, commonly, why does this happen? Hospitalized patients who are on a vent because the vent pressures are too high. And it'll burst those alveoli because the lung doesn't care. If you're trying to push more air in, it can only handle so much. So your vent patients, this can be done. A lot of times you need a CT to diagnose it because it's so minuscule that x-rays don't even really pick it up. Because what it is it's air in the interstitium. It has it, so you can see the small little pneumothorax out here on the CT, right? It's right there. That's why CTs are studying choice of pneumothorax. Look at that. I'm not going to see that on an x-ray. Okay? But what we're looking at, that pulmonary interstitial emphysema is air around the pulmonary vasculature due to ruptured alveoli. Okay? Got some more pneumothoraces down here in the basilar area. That's what the white dotted arrows are. We're really seeing the black lines around the vasculature if you're pulmonary interstitial emphysema. You can see why that you need a CT for this. You're not going to see that on an x-ray. Yeah?
That's with contrast, not a
So correct. So this particular CT is with contrast because I can see all my vessels. You can see the aortic root up here. This is an old patient. They got some issues, right? They got a calcified aortic root up here. That's what that is. So this is with contrast. You don't necessarily need to do contrast to do this. It just happens to be this image. It's just no CT. Pulmonary interstitial emphysema, CT. Okay. X-ray is not going to see this. It doesn't want to change pictures. There we go. Okay. So yeah, there's that. All right. Subcutaneous emphysema. Air in the subcutaneous tissue. There's your definition of that. What else is on this X-ray? We got a chest tube in. Why do we got a chest tube in? Pneumothorax. Here's my lung. Right? Definitely a trauma, but here's your subcutaneous emphysema up here in the upper areas and down here on the side. Should we have air in our soft tissue? No. If we have air in our soft tissue, then that means something is going on. Likely a trauma, realistically, probably a pneumothorax. So this would be one of those signs where maybe if you don't see a pneumothorax, but if you see subcutaneous air, you might turn around and go, let me double check that again. Because how the heck did that air get there? How did that happen? A lot of times it came from some kind of rupture in the lung or pneumothorax in some way, shape, or form. Trauma can absolutely do that, right? Because I'm coming through from the outside, causing an issue, and then we're going to have air in the subcutaneous tissue. But really what it is, it's air dissecting the muscle bundles. And we'll see another picture of it. When you see it, like, it's in the pectoral. And you'll see what that looks like on an x-ray. And it's pretty cool looking, actually. You see all little narrow fibers of the muscle. Because again, air is going to act like that background. It's going to make that stuff, those muscle fibers pop a little bit more, because now I have air back there that's not supposed to be there. I think it's actually the next slide. Yeah, check this one out. So this is air in his pectoral muscle, so I can see all these striations coming across. Because he's got subcutaneous emphysema, not just in the subcutaneous tissue, but also going into that area as well. Because it can go into the neck, it can go into the chest, it has that striated type appearance coming on down, right? So subcutaneous emphysema tells you there's something else kind of going on there, and we should take a look at it just a little bit more. The white arrow is just trying to show you that striated marks of the muscle fibers. Okay, let's look at these. What's going on in picture 1 on the left? What's going on in picture 1? What's the diagnosis? What do you got, guys? Come on.
Massive.
Okay, massive pleural effusion. How do I know it's a pleural effusion? It's pushing it away, and it's fluid, so it's radio-opaque. Good, good. What's going on in picture 2? Tension pneumothorax. How do I know that? Well, one, I'm missing like my lung, right? That's all black. But then look at my shift. It's pushing. It's pushing that entire mediastinum over, right? What's the treatment for the pneumothorax? Chest tube. What's the treatment for the other one? Chest tube. Same treatment. One we got to remove air, one we got to remove fluid. It's the same treatment. They both need chest tubes. Good. What is that? The interstitial emphysema. Right? The pulmonary interstitial emphysema. And if there's only one picture I've used to show it to you, you can guess there's not a whole lot of them out there for me to pick from. All right, I'll tell you what. Getting into pneumomediastinum and pneumopericardium is whole section kind of on itself. So we'll call it good there. I'll see you guys tomorrow morning, and then we'll jump into those ones. I'll hang out if there's any questions.